Thank you all for joining today. Um, Today, myself and Dr. Pooja. So I'm Dr. Fred, consultant endocrinologist at Tata MD. Dr. Pooja is my colleague, another endocrinologist. She leads our weight management services. So both of us will be talking on this topic called obesity. Um, and we're looking at some of the recent advances in the management of obesity. Obesity is a very frustrating topic. There's a lot of stigma associated with it. People are often not aware of what are the consequences of obesity, what are the problems that they can face with it. Also, they're also often unaware of what are the options available, how to take care of it. What are the medical options available? I know there is a lot of hoopla in the news of late with the GLP-1s. So that's why we thought we'd do this webinar, trying to clarify some of the myths and also look into the recent introduction of the GLP-1 receptor agonist in the Indian market. So we just want to shed a lot more light in it. So towards this, Dr. Pooja will take it away from now. So I'll hand over to Dr. Pooja to get started with the talk.
Thank you, sir. So we'll start up. So as you know, that obesity or weight gain is which was there was an era where people thought that it was eat less and you move more. That would be a starting point where you lose weight. But let's see how obesity or this weight gain is a complex disease where you have to take help in order to reduce weight. So the first thing is why we Indians stand a little bit different when compared to the Caucasians is even at a lower BMI. The BMI means what is BMI is a body mass index where your body weight is compared against your height. And for we Indians, usually at lower BMI also at 23, over 23, we are known as overweight. So we are in this thin fat phenotype typical era where even at lower BMI, we will have high visceral fat. So that's why the cutoffs are at a lower level. And genetically, we are predisposed to heart disease and other complications at a lower BMI when compared to Caucasians.
So typically, you'll see that BMI of over 30 is considered obesity in Caucasian populations. But as Dr. Pooja mentioned, for any given weight, we tend to carry a lot of abdominal fat. So if you see Westerners, they tend to have, even when they're overweight, like a cylindrical, as in they put on a lot of fat, but mainly around the under the skin. Whereas our Indian population, or the Indian subcontinent for that matter, we tend to put on a lot more abdominal fat. And this abdominal fat or the visceral fat is the actual danger. And that's the reason what we find is that the BMI cutoffs for Indian standards, anything over 27 is actually considered as obesity. So that's something that we always need to be aware when we are looking at our weight.
So are we measuring the right thing? Though BMI or the body mass index is the screening tool, the first place which takes is the body composition analysis. So what is this body composition analysis? It is a tool which is used to measure your visceral fat as well as muscle mass. So it comes as a machine where you will know how much visceral fat you put on. So less than 20% should be in male and less than 30% in women. And it also gives us a rate of how much skeletal muscle mass should be there. And second thing is the waist circumference. This waist circumference also acts as a surrogate marker for your visceral fat. Or what is this visceral fat? This visceral fat you're talking about, doctor, if you ask me. So this visceral fat is nothing but the dangerous fat which sits around your major organs like liver, pancreas, and that is the risk factor for your long term complications such as diabetes, hypertension, and even fertility issues are caused because of this fat. So the tracking pattern, the first thing is body composition analysis. Sometimes in most of the clinics this tool is not available. Then the second thing we go for is the waist circumference or the waist hip ratio. Usually it should be less than 90 centimeter in males and less than 80 centimeter in females. So coming to then the last thing is the BMI. BMI is where it's a screening tool, which I already told you is weight by height square, and that can be used if both the parameters are not taken into consideration.
That's right. As Dr. Pooja mentioned, every tool, any tool has its own limitation. It has its own pluses and minuses. So BMI is very easy, very simple to get done. So that is why it tends to get done very commonly. But obviously, it can hide a lot of nuance. So that's the reason the preferred option is the BCA and the waist circumference. BMI can be used as a routine screening tool as long as we understand the limitations. So just because the BMI is less doesn't necessarily mean that you don't have a problem, and we'll see some data about this in the further slides.
So this is a very important slide. So if you think your weight is like an iceberg, so the tip which you see is nothing but the visible weight, like the abdominal circumference or the neck fat. But what actually lies underneath the 85% of it is how the biology is causing this weight gain. So initially we thought that weight is nothing but you eat more or you don't do much of physical activity, but the biology inside is more like genetics come into factor, family history, metabolic adaptation, like the sleep patterns are not regular, you eat late, food timings are not regular, and there is a lot of insulin resistance, which means that your body is producing excess of insulin to maintain sugars, and that triggers increase in body weight, and environmental triggers such as stress, infections. So all these contribute towards weight gain. It's not only the calorie thing, it is so much of biology inside. So let's see how this biology goes forward.
So this kind of pattern or the iceberg pattern actually works for most metabolic diseases. The body has a huge amount of compensatory mechanisms to maintain status quo, and that's the reason you don't tend to see the problems until it is quite late. And we often tend to think of, as Dr. Pooja mentioned, this is a plain and simple calories in, calories out. But there's a lot more to it. There's a lot more complexity to it. There's a lot that's in your hand, but there's also a lot which is handled by biology, which just normal diet and exercise cannot overcome.
So let's see what it is. Like Dr. Fred said, it is not like a calculator, like eat you. So you are eating more, now you eat less. No, so you moving more, so you move less. So this set point which is there is like a thermostat. So it is at a point where you are eating more calories and everything, and it is set at that point. Suddenly, if you start cutting down on your calories, or you go on a crash diet, or you do, what happens is the body goes into a energy conservation mode. It will fight back, so it will start increasing your hunger hormones, and because of that, your satiety hormones also come down. So because of that, what you will have more cravings, you will eat more. So you suddenly do a crash diet, you lose some weight, and suddenly you gain the weight back. This yo-yo phenomena is you gain weight again. That weight gain will be little bit more stubborn to lose. So this is how the biology works. So you have to reset the thermostat than just controlling the room temperature.
That's right. So this is a blessing and the body is always trying to maintain status quo. That is the point. So once you start cutting down drastically on your calories, or you start spending a lot of calories by just exercising a lot more, the issue is the body determines that something's going wrong and it needs to correct. So this is a maladaptation. So what happens is the body just slows down the metabolism. It starts spending less calories, and that's why you see the yo-yo phenomenon that Dr. Pooja mentioned.
Yeah. So our goal is not size zero. So it is not a cosmetic issue. That's what we want to say today. So weight gain or obesity is not a cosmetic issue. It has lot of health problems underneath. So even if you start off with 5% of weight loss, you start seeing the changes. There is regularity in the cycles in patients with PCOS. And when you come to 10 to 15% of weight loss, there is reduction in medications for people who are diabetes, hypertension. Sometimes people have gone into remission also. There is fatty liver reduction. And with 15% weight loss, there is so much reduction in your cardiovascular risk, like stroke, heart attack. And above 15% is a bonus for you. So that is like, weight loss is adding on to your years. That's what I can say. So it's not only a cosmetic issue. It's not only like people just do it for 3 to 4 months, saying, "Ma'am, my marriage is nearby, or I have to go for a foreign trip, so I'm losing weight. So help me with that." It shouldn't be like that. It's not a cosmetic problem. You should take it this as your lifestyle. And weight loss, initially it will be difficult because your basal metabolic rate is low and your body fights back. But over a period of time, it will once you start losing weight, it will slowly improve, and that should become your lifestyle forever. That should be the key.
That's right. So the aesthetic changes are nice to have, and I'm sure everybody, when we lose weight, we always feel a little good, and in terms of our self-esteem, etc. But that's a secondary thing. Another key takeaway from this slide is that even 5% of weight loss does make a difference to your metabolism. So it's not just about the quantum; it's about the lifestyle, maintaining a particular lifestyle, trying to get some weight off, even if it is not a huge amount. If you're able to lose some weight, that makes a big difference. Not everybody will be able to lose 15-20%, but if you make a conscious effort and lose even 5 to 10%, that makes a big difference. And these are not small issues. I mean, if you can avoid diabetes, or if you can avoid fatty liver or a heart attack or a stroke, that has huge implications, not just health wise, also financially as well.
So the myth is these GLP-1 analogs are a magical pill. No, the non-negotiable factors in are mainly the lifestyle, that is the diet and the exercise. So good diet with low carbs, high protein, high fiber, with exercises which includes aerobic as well as strength training exercises 3 to 4 times a week is a non-negotiator. So what happens is when the initial push is given by the GLP-1 analogs. So you can just imagine lifestyle as a break, and because of which your metabolism was stuck. It is not, and this GLP-1 analog acts as a missing link, which helps you improve your metabolism so that the lifestyle factors such as diet and exercise, which will help you, which will gear it up, it will fuel towards the weight loss journey. So that's how it happens. And I would say exercise is very important, diet is very important. Why? When you take you off these medications or when you want to taper it, so you have a strong foundation, your muscle mass is built, so that the whatever waste you have lost doesn't come back again faster. So that's the whole key for anything. The foundation is diet, exercise, reduce stress, good sleep, improve your metabolism, and GLP-1 analogs will give you that extra push, acts as a connector.
That's right. And this is something that I think most of us who've tried to lose weight would have noticed it at some point or the other. The common complaint that we tend to hear as doctors is, Doctor, but I'm doing this, I'm having a good lifestyle, I'm eating healthy, I'm eating clean, I'm exercising, but I'm not seeing that result. I'm not, the scales are just not budging. And that getting stuck happens because of the hormonal changes that happen internally, and that's the cycle that this GLP-1 can help break. But at the end of the day, the effort has to be there. It just cannot be magic.
Mm. So, doctor, how does this GLP-1 medicine work? So, GLP-1 is a natural hormone which is actually produced in our by our gut. It is known as glucagon-like peptide. So these peptides mainly help you to act on the brain to maintain the appetite or the satiety. So, this gut-brain axis is where the full signal comes, and it also slows down your gastric motility. So once they slow down your emptying, so there is a decrease in absorption and you feel full at a lesser food only. And also it increases your insulin sensitivity because it shifts your energy from the fat storage part to the energy expenditure part. So this is how the GLP-1 analogs work, basically reducing your appetite, slowing your gastric motility, and increasing your insulin sensitivity.
It's not just about reducing the food intake. There are a
Mm.
lot of neurohormonal changes that happen. There are a couple of hormones that work on the brain, the leptin and ghrelin. Both of these together, the interplay between these two actually determines your appetite and satiety. So controlling these hormones, or moderating the effect of these hormones, plays a big role, and we'll see that this in the further slides. So it's actually quite a complex hormone. It has multiple effects. What we've seen here on this slide is the effects related to weight and appetite, but equally it also has additional effects. It helps protect the kidney in people with type 2 diabetes. It helps protect the heart in people with cardiovascular disease. So it has multiple benefits. It's not just about the weight loss.
Hmm. So, what is this silencing the food noise? So, as I already told you, when you go into that energy conservation mode, your hunger hormones goes up, and you start feeling like eating more, or you have lot of cravings, and this constant background noise is there, thinking about food, like how much to eat, what should I eat, should I take this, should I? That hunger pangs are there. So, can't stop thinking about food. So such feeling usually comes down with the GLP-1 analogs, and it shuts down the reward for that hedonic eating, what is known as pleasure eating. So that's where the appetite control comes up and your satiety levels increases much more. So people ask me, "Sir, madam, if the appetite completely comes down, then how do we do?" So the body will take as much calorie as it wants. So once you stop, you shouldn't eat over your full. So that's where how much is needed, it will take it and then you stop it. So the appetite also comes down, the energy consumption is also more, and the expenditure is also more, like that.
That's right. So the concept of hedonic or pleasure eating is very important to understand here. So there's stuff that we need, and then there's food that we want. So it's this want factor that gets curtailed with these medicines. Often, what we find in terms of calorie intake is the actual meals may not be very high in calories, but then the little snacks that people tend to have in the middle of the day. So, for example, two rotis is about 300 calories, but at the same time, a bag of chips will be 350 calories. One would be considered a meal, and one would be considered nothing. This kind of pleasure eating, eating when you're not hungry, when you're depressed, when you're feeling low, emotional eating, these are the things that come down and they contribute a lot to the calorie restriction.
So though these GLP-1 analogs reduce the fat, sometimes they reduce the muscle mass also. So you have the non-negotiators are, you have to have good protein diet and also strength training 3 to 4 times per week. So as I already told you before, the diet and exercise should be parallelly running, and your GLP-1 analogs will be parallelly running for your weight loss. So basically, this side is to maintain your lifelong commitment towards good lifestyle, and this is to that initial push of 10 to 15% of weight loss, mainly to get back to your normal metabolism.
Right. So the strength training, you would have noticed the pattern here. We keep coming back to this, that the muscle building exercise is really the key. So this is
Hmm.
not just true of GLP-1s. If you were to lose weight on a diet, be it naturopathy, be it keto diet, it doesn't matter what form of diet or whichever pattern you follow. If you lose weight and you're not careful, you are likely to lose both muscle and fat. So the idea is when you're on any weight loss regimen is to try and maintain the muscle mass, and that's why the strength training is important. Just the protein intake will not do. I think I need to make that very clear. Eating a lot of protein doesn't necessarily translate to a lot of muscle. You have to force the body to build muscle, and which means the strength training, and that's why the strength training is non-negotiable.
Yeah. So So how do we tackle this issue in the clinic? So mainly we go through a set of diet counseling, the physiotherapy for the muscle building part, and as well as if there is any psychological issue or a behavioral issue, a psychological counseling. And basically we see how to titrate this GLP-1 analog. So we start off at a lower dose and slowly increase the dose, basically because of the side effects such as it reduces the gastric motility, there is slowing of the gut. So people can have nausea, vomiting, so little bit of diarrhea sometimes, and that is only 5 to 10% patients start off. But as you subsequently you feel better. So that's where our role comes, the safety titration. And I constantly say patients not to take it without any doctor advice. So supervision is very important, mainly to titrate the dose to see how much weight loss you're having. Some people lose a lot of weight, some people don't lose weight, but we have to do it in moderation. So that's very important. And parallelly doing physiotherapy, strengthening your muscles, and having a dietitian together, we it forms a multidisciplinary approach or a holistic approach towards weight gain or obesity.
Yeah, so this is not something that one person can handle, and you often need multiple people stepping in and contributing their expertise to give you that multidisciplinary approach to achieve your results.
Hmm. So some people ask me, is it a lifelong commitment, or should I take it lifelong? So usually we say, depending, it is a personalized approach. Usually we ask them to take at least for 6 months when they start off with the drug. So we start off, as I told you, with a lower dose, then slowly titrate it and maintain it at a maintenance dose. So once there is 10 to 15% of weight loss, we usually maintain it at a maintenance dose, and by that time, if you're okay with the this thing, we slowly taper it and stop down. Sudden stopping also may lead to rapid weight gain. So that's where a maintenance dose is given and then slowly titrated down.
So this actually, I'm sure this will bring up a lot of discussion later on. Um, so there are two ways of looking at it. One is the weight loss effort a long-term commitment? And the answer is yes. So if you just take the medicines for 6 months or 1 year or 2 years and then you stop it, but you're not careful on the diet and exercise, it will come back. There's no doubt about it. It might take a couple of years, but it will come back. So what we are talking about here is use these medicines, get 10, 15, 20% of the weight off. When that happens, your eating habits change, your exercise capacity changes, your mental state changes, your motivation changes, and you often find that you're able to maintain the weight much easier than previously. So we might be able to get away with smaller doses, longer gaps between doses, or intermittent doses, or milder medications. So there are lots of options available, and including stopping the medication. But the continued effort has to be there. If
Correct.
you just think that, okay, 6 months GLP-1, now I'll switch off and I'll be normal, that's not going to work.
Yeah. So that lifestyle should be constant, and weight loss is like an effort, long term. So coming to the side effects, what can be the side effects, which is the most important part, which everybody asks in the clinic. So usually, as I showed you, there is some amount of nausea, vomiting, because there is slowing of the gastric emptying. So, but that improves with time. So once we start off with the lower dose, that's why we start off with the lower dose. Some people ask me, why can't you give the higher dose? So we start off with the lower dose to maintain or monitor these side effects, and these side effects are treatable and there is nothing to worry about. And you should hydrate yourself aggressively. So what happens is, when the appetite is lowered down, so you tend to drink less of water also. So hydration also helps you in slowing getting off this thing. And one more key thing is, you should eat small frequent meals, and spicy food should be eaten less. And once you feel full, after that you shouldn't eat. So those are the three key important points how to reduce the nausea part. And after that you develop a tolerance and you will totally feel comfortable with the medication.
That's right. So the discontinuation rate is only about 5% or so. So
Mm.
95% will be able to tolerate it. And the coping strategies that Dr. Pooja mentioned, those are very important. So key thing is small, more frequent meals, low fat, less spicy, less oily, and when you feel full, stop. That is one thing that lot of our people tend to struggle with. Trying to finish off what's on the plate can often trigger. Or if it's dinner time and you don't feel like it, oh, but I need to have dinner. No, don't do that. So if you don't feel like eating, don't eat, and it'll be fine. The appetite will come eventually, but in the initial stages, overeating can trigger the side effects.
So, what are the red flag signs where we don't start these medications? So, if you have a family history of medullary thyroid cancer or a history of pancreatitis or active gallstones, so gallstones as such are not a contraindication. So, we have started, but if there is active gallstones or if the stones are in the neck of the gallbladder, then we don't start it. Then pregnancy is a complete contraindication for these medications. And even when you're planning for pregnancy, we stop it for a 2 month period for the washout. Then we ask them in that period, we put them on pregnancy safe medication such as metformin. Only then they can go into pregnancy. So these GLP-1 analogs don't have much data in pregnancy and post pregnancy. So we don't. So there is a complete contraindication. 2 months before, stop it, plan pregnancy, then you move on with it like that.
Yeah. So we do use these drugs in people who are overweight and are struggling to conceive. But as Dr. Pooja mentioned, before the pregnancy actual or the actual conception, at least 2 months you need to be off it because it has a very long half-life. That's why the 2 month duration is there. So there's no harm in taking it for 6 months, losing 10, 15 kgs, getting your weight sorted, then coming off the medicines for a few months and then conceiving. It's just that you should not conceive on it.
Mhm.
Similarly, these other problems of medullary carcinoma, thyroid, these are very rare cancers, and gallstones, just the presence of gallstones is not an issue. So these are relatively minor side effects, but this is something, or minor contraindications or relative contraindications. So this is something that you need to discuss with your doctor, and the decisions will be made on an individual basis whether it is safe enough for you to go on these or not.
Yeah. So coming to, are you a candidate? What is the medical criteria where we start off on these medications? So BMI more than 30 for an obese patient and BMI more than 27 with overweight or any of the comorbidities like diabetes, hypertension, fatty liver or sleep apnea, we start off on these medication. So for diabetes, any BMI criteria is taken because initially these drugs started off as diabetic medications, which later had lot of impact on weight, and it was then used for weight loss also. So this is the criteria where we start off. So we have people with lesser BMI also coming up to us, ma'am, start us on these medications, but these have been these have to be given only in these patients.
That's right. So these are the licensing criterias. So if you go beyond this, then you're essentially going in uncharted territory. So it becomes very difficult to judge how things might work out. The BMI is not an issue as long as you have diabetes. So if you're a diabetic, the BMI doesn't really matter. Often you'll find that people with diabetes will be on slightly lower doses of lower end of the dose range. But if you're using it purely from a weight perspective, you need to have a BMI of more than 30 without any complications, or BMI of more than 27 with at least one comorbidity. So either overt diabetes or pre-diabetes or hypertension, etc., etc.
So, what are the key takeaway points after this entire presentation we want you to take home? So, the obesity or weight gain is not just weight, of the visible part, like eat less, eat more. By the end of this presentation, I hope you would have understood how important or what the biology is, how complex it is in order to lose weight. So there is a time when you can do it with diet and exercise, and then it comes a time when you cannot do it with diet and exercise, and you need help. So take help and lose a little bit of weight, and that will also help in a long term health complications also. And it's not only the cosmetic issue; it is a health issue also. This is one important point which I want you to take away. And second thing is this GLP-1 analogs. Initially, we had bariatric surgeries and all sort of surgeries for patients who were with high BMI, that BMI more than 35 or BMI more than 40. But now we have these medications, so which have much better outcomes and much better uh, health benefits. So muscle preservation is the priority. There is no excuse for diet and exercise, and include strength training in your schedule also, that to 3 to 4 times per week. And prevention is cheaper than cure. Yes, this is a very important statement. So patients tell me that sugar is borderline hai, my lipids are in the borderline, my sugar is in the borderline. So we will wait for it. We will do diet and exercise. We will see. And that Josh will be there only until the patient goes out of the clinic, does it for 15 days, then it is off Josh. Then back to the same one. Borderline, hey, we can see it later. No, these borderline things are where you have to pick it up. And these small changes or these soft markers have to be picked up initially. Why your body is struggling? Because there is a lot of reserve in your body. Imagine a machine is overworking, and it'll stop at some point of time. And suddenly, to make it work again, you need a lot of time. So studies have shown that first 5 years, how you maintain your sugars, how you maintain your weight, everything has effect on your microcellular level for a long-term complication. Why prevention is very important. Before, when we used to study, like patients above 45 used to be mostly diabetic, but now there is complete drastic shift of 20 years down the lane, where even a 20-year-old, 30-year-old is getting diabetes, hypertension, he's obese, or have fertility issues. So there is almost like 20-30 years for him to stay with this metabolic syndrome, and he will in at one point of time face lot of complications. So that's where this prevention plays a very important role. And this is very important. So you take things earlier, you manage it earlier, and go into remission earlier.
I would emphasize on 2 points here. First thing is the first, so before you can find a solution to a problem, you need to accept that there is a problem. So often the tendency is that I'm just a healthy individual, khata pita family hai, ye hai, wo hai. So if you don't understand the implications of being overweight, then you cannot handle it. So therefore, first thing is to accept that there is a problem. So screen yourself, check yourself out, find out if you have more abdominal fat, find out if your BMI is normal. Once you know you have a problem, you can deal with it. The solution need not be the GLP-1s, but at least you can deal with it once you know that there is a problem. And the second important thing Dr. Pooja mentioned was that the prevention is cheaper than a cure, because this is not something that begins and ends with weight. Weight is just the initial stage, and then this progresses into fatty liver, your cholesterol, your blood pressure, your diabetes, your heart attacks, your strokes, all of those things. Now, imagine if you can deal with this at the obesity stage, and then you don't have to deal with the diabetes and the heart attack and the stroke. Naturally, it's not just a matter of being more cost effective. From a health point of view, from a quality of health, quality of life point of view, it makes a huge difference. So therefore, always think about getting in early and getting things under control so that your long-term health is maintained.
So
So I think we'll open to questions then. Anything else you
yeah,
wanted to add, Dr. Pooja?
no, that's it. We'll open for the questions. Yeah.
So I'll just look at the chat box.
Mhm.
So there's one question here. I'm not sure who it is from. Hello, doctor. How about perimenopause cases? Would you like to take
Mm.
that?
Yeah. So perimenopausal, this is so, okay. So perimenopausal cases, usually there is lot of hormonal change, mood swings, and along with that, we have patients coming where they have depression, eating, and a lot of weight gain is there during this transition from perimenopause, menopause, and postmenopausal. So whatever the weight gain is during this period may be because of little bit of hormonal changes, and also mainly a big contributor is also the diet and the exercise part. Since we feel that we have a little bit of less stamina, we don't do the exercise properly, or the diet is not being maintained properly. So these medications are good in that era also, but you should meet the licensable criteria. But what I would suggest is a little bit of hormonal evaluation followed by your metabolic evaluation, and that will keep a check on both your symptoms of perimenopause, menopausal symptoms, and your metabolic part should be maintained mainly by the diet and exercise, as we told, which is the non-negotiator, followed by, if you're on the higher BMI, or if you have a little bit of comorbidities like diabetes, hypertension, we could help you with GLP-1 analogs so that the transition is smoother and you also maintain your weight. Anything else you want to add, Dr. Fred?
That's it. So yeah, so menopause, perimenopause, that does not matter. So if you have a weight problem, it can be dealt with. But again, the answer to the weight problem or weight management is not just GLP alone, as Dr.
Mm.
Pooja clearly mentioned there. It has to be a combination of diet, exercise, and medicine. The whole thing has to be taken care of. Next thing, can weight loss on these medicines reduce? Okay, can people lose weight? I think that's what they mean. Once they lose weight, can they get off medicines for other chronic diseases like hypertension, high cholesterol, etc.? Pooja?
Yeah. So, as I already told you, so we on these medications, there is significant drop in HbA1c also, 1 to 2%, 3% drop in HbA1c. There is better control of sugars. So we actually reduce the diabetic medications when we put GLP-1 analogs. So we tend to reduce the sulfonylurea, which is there. We tend to reduce almost 20 to 30% of the insulin dose also, if a patient is on insulin. So these medications, I would say, was initially started off as a diabetic medication, which later had was known to have very good cardiometabolic effect, which on weight loss. So so the answer to this question is yes, it will reduce your diabetic as well as the hypertensive medication. See, what I can say you in simple terms is the root cause for all your metabolic thing is your weight. And this weight is not just weight on the number scale. It is your subcutaneous fat, is your visceral adipose tissue. And this is the dangerous fat which is present around your liver, pancreas, which is causing all this insulin resistance. So एक बार आपने the root cause is just removed, then all your upper three part, whatever the diabetes, hypertension, slowly comes down, and it becomes, maybe you will be off medications, you can be maintained on lesser medications. So all these effects are seen.
That's right. So we saw in one of the slides previously as well. So more the weight loss, better the improvement in your chronic diseases. So 5% can help with your PCOS cycles and so on. 10% can help with reducing diabetes risk. 15% can induce diabetes remission. And the same thing applies for hypertension, etc. As well. So any amount of weight loss over 5 to 10% is considered as significant. And you can find that obviously if the conditions improve, then your need for medicines obviously goes down along with it. There's another question. What about patients who already have high acidity, acid reflux, and gastric issues? How does it work? Please, I'll take this one. So just because you have acidity issues does not necessarily mean that you cannot take these medicines. So quite often there can be some triggers such as habits such as eating very late or oily foods and these kind of things, or something just as simple as head end elevation can take care of the reflux issues. So it doesn't automatically disqualify you from taking it, but yes, we have to use it with caution. We would try it out with small doses, and then we see if you're able to tolerate it. Just because you have some acidity issues doesn't necessarily mean that you cannot try it cautiously. There's another question. Hello, doctor. Can you please share the expenses related to the various GLP-1 drugs and their required doses? Dr. Pooja?
Yeah, so we have basically two types of GLP-1 analogs now. One is a semaglutide and the tirzepatide. We have many more also, the liraglutide. So all come in different ranges. So the liraglutide is a daily injection which comes at around 3 to 4K per month. And next we have dulaglutide, which comes in weekly once injections, and that comes up to 6 to 7K per month. And the third option is the semaglutide. Semaglutide comes with two brands. One is the Ozempic and the other is the Wegovy. The Ozempic comes with only three strengths, and that will be like it's start off with 8K, and it as the dose increases, it can go up to 10 to 12K. Whereas the Wegovy will start up to 14K and then it'll go up to 20, 17 and 24K. And so coming to tirzepatide is a GLP as well as the GIP-1 analog. So here we have two brands, that is the Urpeak and the Monjaro, and two different brands have little bit price variations. So the Urpeak comes at to around 8, 10 starting, and as the dose increases, it can go up to 14 to 17K. And similarly with Monjaro with 10, 12K starting, and then it goes up to 17 to 18K. But one good news, it is going to go off patent, so we will see many brands coming up with these options. Yeah.
That's right. And so as the particularly semaglutide, the patent's going off. So the next couple of months, we expect that there'll be generic versions. So that should
Mm.
bring down the prices significantly for the weekly ones. Semaglutide. Semaglutide is your Ozempic or Wegovy.
Mm.
There's another question here. I'm a postmenopausal woman. I'm on liraglutide for the last 4 to 5 months, but no weight loss. What to do? Any specific things to observe for menopause? So,
Mm.
so liraglutide, the one challenge that we had was the liraglutide that's licensed for weight loss is actually the 3 milligram dose. So what we are using, what you're probably using is probably 1.2 or 1.8, which is not really a weight loss dose, and that's considered as a diabetic dose. We have been using it because we just didn't have access to the high dose versions. So the fact that you're not able to lose weight on liraglutide, I think the natural thing to do would be to step it up. So you can try semaglutide or tirzepatide. So speak to your doctor, and they will guide you to make the right choice. But the other drugs are a lot more potent than liraglutide at the sort of doses you'd be taking at the moment. Now, coming to answer your menopause issue, as Dr. Pooja already previously mentioned, the menopause itself is not an issue. But around menopause, it's all the more important to make sure that the exercise aspect is taken care of properly. So please do it under guidance. So the last thing you want to do is do something yourself and hurt yourself, and then 3 months if you're not able to do exercise, that just sets you back. So make sure that you do it properly. Get a trainer, join a gym, or join a class under some sort of supervision, so you don't end up setting yourself back. I hope that answers your question. Then there's another one. If the parent doesn't have diabetes, how does it work on the body? Will it cause diabetes? Yeah, I think
So
that's okay. I think what they mean is that does the family history have a role to play? You want me to take it?
yeah, I'll take this.
Okay, so yeah, sure, go on.
So basically, the family
What do you want me
history
to
is
take?
uh,
Go on.
so the patient wanted to ask, I think if the
Or I think it's a
family
parent. It says
then
sorry. The patient's clarifying there. It says patient, not parent. So if the patient
mm,
doesn't have a history of
mm.
diabetes, how does it work?
Yeah, so equally good. So as we already told you in the previous slides, where the BMI more than 30 is there, and even if you have weight gain, so these GLP-1 analogs help you to reduce that weight. So even though if you don't have any comorbidities, or you're on the borderline of pre-diabetic, or you're not diabetic also, so these medications, as we already told you, that it reduces your appetite, it brings down your gastric emptying, it increases your insulin sensitivity. That's the most important part, where the insulin resistance comes down and your cycles will become much better. Your weight loss will give you that, even though if you don't have diabetes also, future may whatever complications you can have, that is prevented. Second thing, your fertility also improves. You will feel much better. The basal metabolic rate improves. So it has equal effect on your weight reduction, even though you don't have diabetes or hypertension.
That's right. So the weight is actually a marker of somebody who's heading towards diabetes. So even though you may not be diabetic yet, the fact that you're putting on weight and a lot of it is going around the abdomen, etc., that's telling you that you're insulin resistant. And that's the reason these medicines work in non-diabetic individuals as well. because the underlying problem here is insulin resistance and issues in terms of appetite management. So the fact whether you have diabetes or not, that doesn't quite matter. If you have weight issues, then these medicines do help. There's another interesting one, Ozempic phase prevention. So this is, I think, one Mr. Karan Johar has made this very popular. So this is why doing it in a supervised manner, in a proper manner, not aiming for huge amounts of weight loss in one go is important. So the weight loss has to be done in a gradual, controlled manner. So if you lose weight very rapidly, your skin does not have time to adapt, and that is what gives rise to these issues. So as long as you do it under guidance, gradually, not in a hurry, don't jump doses. You should not be losing 6, 7, 8, 10 kgs in a month. As long as you avoid those kind of scenarios, you should be fine. If you still end up having to lose, like 40, 50, 60 kgs, then it may not be avoidable. But for most people who are losing 10, 15, 20% of their body weight, it should not be an issue. How expensive are these medicines? I think Dr. Pooja answered that quite elaborately. And as we said, semaglutide is coming off patent. So the cost going forward should not be as much of an issue. It should come down to the 4 to 5,000 per month. But as of now, it's around 8 to 10,000. Sorry, Dr. Pooja, do you want to add something?
Yeah, I just want to tell, like, see, when compared to the money or the health issue, most of them are asking how expensive it is, but your health is more expensive than these medications. I would say weight loss is very important, and the chronic complications which you develop slowly at a microcellular level, which may not be visible 5 to 10 years, but down the lane, it is going to make an impact, the weight, how you maintain it now. So, for expensive, yeah, people who cannot afford, there are other medications, or at least you can go for strict strength training, weight training, and some other medications which are at a lesser cost, is what I wanted to add.
Yeah. And the cost is constantly coming down, so I'm sure it will become more and more attainable. But one point Dr. Pooja mentioned is that is the cost and value. So spending 10 rupees now can save you 100 rupees later, because if you then have to deal with a knee replacement or a angioplasty or a stroke at the ICU admission, what you spend on this will feel like nothing.
Nothing, yeah.
Okay. There's another question. If we have antibody high, how it helps? Not sure I get that question. I don't think there's anything to do with antibodies in terms of weight. Maybe we're not understanding that question. Then, if we take it, will it affect our body production of insulin capacity once we stop taking these medicines? How does our body work? Pooja?
Uh, so this is where I want to say, see, insulin resistance is different from insulin producing capacity. So I will tell you in simple terms, is where the pancreas produce insulin. And because of this abdominal fat, cholesterol, visceral fat, the fat around your liver, in your pancreas, that makes the body overwork to maintain sugars in the normal level. So there is, if this is your sugar level, if you are insulin resistance, the body will be producing so much of excess insulin, where it had to around say work at a reserve level of so much insulin. So once you stop taking these medications, so that's what we were explaining the whole time, your non-negotiable factors like diet and exercise, you should make it as a lifestyle. Once you stop taking this medication, there will there is nothing like there will be stoppage of insulin production like that. Insulin is being produced by the pancreas at the normal levels, not at high levels where there is which we call as insulin resistance. And will it affect the production of insulin capacity? Yes, the machine was overworking, doing high amounts of work to maintain the sugar levels or to maintain the body basal metabolic rate, will slowly aram se work at a normal level. So that's the change we have seen. And if the question, if Lohita really wanted to know, like, it will affect whether the pancreas will produce insulin or not, pancreas will do its work. Whether it is overworking, whether it is doing normal work, that is the difference. That's it.
That's right. So essentially, you're reducing the load on the
Mm,
body. So when you're
mm,
overweight, you're asking your body to work very, very, very hard, and that cannot go on for long. And when you
mm,
take these medicines, you're increasing the efficiency, you're improving the efficiency of the insulin, so that your body has to produce less. So if you can manage with less insulin, naturally whatever you have will last longer, and your body can actually take care of your needs for a longer period of time. So it's actually
yeah,
beneficial.
beneficial. Yeah. So, anybody who wants to ask questions can raise their hand so that we can unmute them. That's what.
And there's another message: will we get any notes and recording for this session? So, okay, this will be there as a recording on YouTube. So we can share the links with you, or if you just follow us on Instagram and things, we'll post over there. Uh, or maybe you can send a message. So we'll organize something to get across to you. You'll be able to see it on YouTube. Uh, uh, there's another question here: how will it produce more? I think you're referring to insulin. No, it doesn't produce more insulin. The idea is that your body should be able to manage with less insulin. So if I were to use an example, so when you're insulin resistant, you have to produce, let's say, 100 units of insulin to keep your sugars in check. With these medicines or with weight loss, what you're doing is 10 units is enough. So your body doesn't have to struggle and produce so many units of insulin. With just producing a little bit, it gets away, which means that the load is less, the life is longer. Okay, so there's another question here. Any detailed articles to understand the difference between GLP-1 drugs? Where can we get that? See, there's a lot of sort of detailed scientific type things. What we can do is, if you give us a few days, we'll put up a blog on our website, and maybe we'll share a link along with the video. Then you can have a look through it. Or if you've downloaded the Tata MD app, then we can certainly share it through the app as well. So leave it with us for a few days. We'll sort that out. Any last? Okay, there's another one. Ramya, can this PCOS hormonal issue with obesity treatable while working in a night shift?
Mhm. See, night shift, I'll take this little,
Yeah.
I'll start it off. Yeah. So, Ramya, the thing is, our body works on a clock. So, what clock? Every brain has a clock, which is a circadian rhythm. The gut, the ovaries, the liver, the pancreas, everything have a clock. So, what happens is in the night shift workers, we have seen that because of this disruption in the circadian rhythm is where the weight gain is happening, and that's why the cycles aren't happening regularly, because night sleep is very important. The 10 p.m. to 6 a.m. sleep is where all your hormones are getting produced, and especially the reproductive hormones, the cortisol. And if you're awake at that point of time, obviously the body takes it as a stressor part. So that is a negative thing, but what we can do is, the obesity is treatable in such cases also. The GLP-1 analogs will help in such cases also, because it acts through a different mechanism. But this regularizing your sleep and this thing also plays an important role. But if you can't do it, you can't. Some people say, "Ma'am, we can't leave our jobs. We can't do the night shift. 1 week we have night shift, 1 week we have day shift." So in such patients also, it will work, but it might work a little bit lesser than compared to a normal patients. But it will do the job. But weight loss will help you with the other issues also. But PCOS as such completely getting treated is without night shift. It depends. It is a personalized thing. So some people do well, some people don't do well. So it depends upon how much your body is put under stress, or how much androgens you have already been producing, like that. Dr.
Understood.
Fred, you want to?
So, yeah, so the night shifts are a constant issue, and
Mm,
professionally, not all of us have the luxury of saying that I'll not work night shifts. But even with the night shifts, ideally, okay, once in 3, 4 weeks, if you're working night shifts and then you're going back to the normal, that's the best compromise. But if you're in a situation where you're not able to do that, apart from the medications, there are some simple things that you can try. It may not take away the effect of the night shift completely, but at least it might be helpful to at least take care of it to a certain extent. One is, even if you're working at nights, try and avoid snacking or eating at night. So try and finish your dinner at a normal early dinner kind of time frame. Try and go to bed as soon as you finish your shift. If it is 2 a.m., 3 a.m., try and get go to bed at that time. Don't sleep through the day. Try and get up at around 8 o'clock, 9 o'clock. Try and stay awake during the daylight hours, and then have a nap before you start your next shift. So people who work through the night and then sleep through the night, that's the worst thing that you can do for your body. Because just body can't just handle it, particularly if it is long term. A week here and there you might get away with, but if you keep doing it on a regular basis, it's going to be an issue. So I think beyond this, I think you should be discussing with your doctor. But at a lifestyle effort, if you're not in a position to get out of the night shifts, then this is what you can do. Avoid eating late at night. Go to bed as soon as you get up. But I mean, as soon as you get off work, try and sleep for a few hours, and then you wake up at a normalish time in the morning, spend a few hours awake, and then take a nap before going to bed. So your sleep will have to be split with the daytime portion that you're awake. That seems to be the best compromise.
The Lohita has raised her hand, so we'll just unmute her.
Yes, ma'am. Last week we tested the thyroid levels. It was doctor was suggested 88, and they did one more test, the antibody test. It is shown more than 200. So this medicine will. What is this antibody and how it works? This medicine, if we take, how can we reduce that antibody level? Actually,
So
it has to be less than 8. But it is more than that, how it body will affect and all.
I think she's referring to the thyroid antibodies, Dr. Pooja.
Yes.
So your antibody is positive means your body immune system has made a mistake somewhere, because this immune system regularly checks your own immune cells for foreign cells, but somewhere it made a mistake that it selected as your own cell as a foreign cell. So what happens is there is lot of antibodies being produced against your thyroid gland, which over a period of time will destroy your thyroid gland. That's why we start you on treatment and keep you on a regular check or follow up. For your second question, Lohita, what can we do for these antibodies? As such, there is no treatment. Just you have to monitor the thyroid hormone, TSH, that is, and maintain it in the range. So if you're planning for pregnancy, we keep it less than 2.5. Otherwise, we keep it less than, we keep it between 0.5 to 4.5. So basically, monitoring the TSH and maintaining it under the normal levels is the key to hypothyroidism with autoimmunity. So you are at risk of getting other autoimmune diseases also over a period of time, or you may not get also. So we just keep a check of that also. So this is how the plan will be.
Yeah. So the
If it is a
antibodies,
keep
they are
on,
not.
if
Go
it
ahead,
is
please.
keep on increase that antibody,
Mm-hmm.
so what we can do, ma'am?
Okay, I'll answer that, Dr. Pooja.
Mm-hmm.
So, see, you don't have to worry about the antibodies. So, first thing you need to do is just stop checking the antibody again. See, the antibody is done to see whether you have autoimmune thyroid disease or not. And we know now, because your antibody is positive, that you have autoimmune thyroid disease, which means that your immune system has made a mistake and it has made antibodies against the thyroid gland. Now, your immune system is going to attack and damage. It has actually damaged your gland to a certain extent, and that's the reason you're needing medicine from outside. So, if your doctor has given you 88 mcg, that means that most of what you need is actually coming from outside. So, beyond this, we don't really worry about the antibody. So, whether it is 60 or 600 or 6,000 really doesn't matter. What matters is what is the TSH. If the TSH is normal, it means that the body is happy with whatever medicine your body is getting. So that's all you need to do. Don't worry about the antibody at all.
How can we get it low by using this medicine also?
No. The medicine is not designed to get the antibody low. Okay. So to get the antibody low, theoretically, what you have to do is you have to give things that will suppress your immunity. Now, if I suppress your immunity, the medicines are toxic. If your immunity is low, then you'll get a lot of infections. So all of that doesn't make sense at all. So that's why we don't do that. And even if we suppress your immunity, your thyroid is already damaged, so you will still need the thyronome as well. So it really doesn't make any sense. So that's the reason we don't worry about the antibody. The damage is done because of the antibody. You just treat the hypothyroidism, give the required amount of thyroid hormone, and that's it. Okay. So you don't have to check the antibody. The titer doesn't matter.
Okay, sir. Thank you.
So, somebody in the chat box, I have a question. We'll just unmute him.
Yeah, hi, doctor. This is Sangamitra. So, I just wanted to know that, as you said, this is some kind of a hormone, right? And it has a lot to do with the brain signaling and all that. Now, let's say if somebody has a pituitary tumor or something of that sort, do you think that tumor might get affected because of this GLP-1? I mean, is there any chance that it might get affected because of that?
Um, what sort of pituitary tumor are we talking about?
Hello, could you hear me?
Yeah, we heard you. What sort of pituitary tumor
Hello,
are you
could you
talking
hear
about?
me?
Yes, we did.
Yeah, yes, we did. We did hear.
What sort
Hello,
of
do you
pituitary?
think you can hear me?
Yes, we can. So, can you hear us? Okay. So the short answer to your question is it's not a problem. It doesn't work on the pituitary cells. So it actually works on only the hunger hormones. It's actually a intrinsic hormone in the body. I hope you're able to hear us. Okay. I'll just answer it. I'm just assuming that she's able to hear us. So the GLP-1s, they don't actually act on the pituitary gland. So there's no contraindication to usage of GLP-1s in pituitary tumors. Uh, this is actually a gut hormone. It's a hormone that's secreted uh, in the in the intestines. Uh, in the in the normal individuals, it lasts a very short period of time, whereas these are synthetic versions which last longer. So therefore, that's why you take it once a week. But there's no contraindication as such to use, as in you should not be using it if you have a pituitary tumor. There's nothing like that.
So somebody in the chat box is asking, will it work for reducing the fatty liver? Yes, we already told about it. So, like the 10 to 15% of weight loss will help you reduce the fat in the liver also. So, this fatty liver is nothing but the visceral adipose tissue, which is increasing as you increase the weight. So that's all comes down once you start losing the weight. So 5%, 5 to 10%, and 15%. 5% is fertility, 10 to 15 is where all your metabolic factors such as fatty liver, cardiac, as well as I think I'll just put the slide once again. And then is the 15% is the cardiometabolic effects you have, Lohita. So it will help in reducing. So grade 1 and grade 2 fatty liver is where once the fibrosis sets in, then you have a different set of medications for it. But grade 1 will gradually reduce and become normal with these medications. Grade 2, to some extent, if the fibrosis has not set in, then it will reduce and come down. But once your liver enzymes are on the higher side, it is in grade 3 or grade 4, it is a little bit difficult. You have different other medications for it. Dr. Fred, you want to add anything?
I think you got the whole of it. So fatty liver is part of the metabolic syndrome, part of the obesity syndrome. So definitely anything that treats obesity will help with fatty liver as well, and it's licensed for fatty liver without anything else as well.
So I'll just show that slide once.
Hmm.
So can you see?
Yeah, let's put it on slideshow.
So this was the slide. So this was the one which most people are asking. So I'll just tell it once more. So this is how the goal is health, and with weight loss, everything comes down. The fatty liver reduction, the diabetes, hypertension, the cardiovascular risk, and your fertility issues, everything comes down with every inch weight loss. Okay. So,
Okay. So if there are no further questions, then we'll close today. So that was a good, informative chat. Hopefully, everybody who attended learned something from it. We certainly enjoyed it. So we'll be putting up this recording on YouTube. So please feel free to follow Tata MD on various social media sites. You can always see this at other times on YouTube. And if you have any questions, do DM us through that. Thank you. Good night.
Thank you. Bye.
Thank you, Dr. Pooja.